Hello and welcome to StoneSmart Live. StoneSmart is a Boston Scientific thought leadership program that is focused on cultivating conversations about your most challenging stone cases. And the StoneSmart Forum is an interactive site on Urology Times, where you can view case studies and discuss challenging urology issues with your peers as you all advance the science of endourology. Now, we are here at the 2017 World Congress of Endourology, of course, in Vancouver, for a live discussion of some of the cases that are featured on stonesmart.urologytimes.com. Now, today, I am so pleased to have Dr. Stoller with me as our guest. Marshall Stoller is a professor and medical director of the Urinary Stone Center at University of California, San Francisco. Welcome, Dr. Stoller.
Thank you very much.
We are so happy to have you here today.
Happy to be here. Vancouver's a great town.
It is a great town indeed. Now, placing double J stents are an important part of managing patients with kidney stones. Most stents are removed after a relatively short period of time, but what about those patients who have forgotten their stents? Dr. Stoller discussed the surgical challenges of removing a highly encrusted stent on the StoneSmart forum. So in your StoneSmart video, you make the point that various approaches can be effective. So we're going to take a look at a section of your video right now. Is that okay?
Sounds good.
We're just going to press this button then.
See what happens. And so the first thing from my perspective is when you see these double J stents that are encrusted and you have large volume stones approximately in the kidney, is to first start in a retrograde fashion to take care of most of the stones in the bladder, the distal ureter, and go up as high as you can up the ureter to be able to remove as much of the stone and possibly even cut the double J stent if need be, so that when you subsequently go in percutaneously, you could take the stones from the kidney and the proximal encrusted double J stents out. I'll probably typically use a cystoscope, and I'll use a laser or an electrohydraulic probe to get rid of as many of the stones, or all the stones from the bladder, so that then I can put up a semi-rigid ureteroscope from the ureter orifice up as far as I can. That allows me to use a laser, baskets, and a variety of other equipment to remove as much of the stone from the distal ureter as I can. These can be very tedious. You also have to do appropriate antibiotics because a lot of these have obstructed systems proximal to these encrusted double J stents. When you go percutaneously to be able to do either antegrade stone removal and antegrade ureteroscopy, classically we've taught to do these in an upper pole puncture, which is fine. You don't necessarily need to do an upper pole puncture. You can do a middle pole puncture also, or even a lower pole puncture with the flexible ureteroscopes. Then you put your wire in, use a dilating system of your choice, and once you have a sheath into the collecting system, you either can place a nephroscope and or a flexible ureteroscope to go on down to be able to pull out that encrusted double J stent. Sometimes you need to cut the double J stent just to get it out of the way, and you can use a laser to be able to do that process.
Well, removing these encrusted stents is certainly a challenge. Are there particular patient factors that make you concerned about rapid stent encrustation?
So I think when you see a patient with a forgotten encrusted double J stent, you need to give reasonable expectations of what it requires to remove the stent. Typically, it requires more than one procedure in a retrograde or an antegrade fashion. And I think it's the responsibility of the physician who places the double J stent to ensure that the patient comes back to have it removed. Frequently, when they are forgotten, they come to tertiary centers like mine, and they come with these vastly encrusted double J stents. It is important to give reasonable expectations of what needs to be done. As I said in the previous video, it is important to first go in a retrograde fashion, deal with the distal curl in the bladder first, and then deal with the distal aspect of the double J stent utilizing a laser, and take as much as you can out in a retrograde fashion first. I think it's the time that's more important. Those patients that have stents forgotten for 6 months, a year, 3 years, 5 years out, those are the ones that are the true challenging cases.
Yeah, of course. Now, in terms of setting expectations, do you typically remove encrusted stents in a single procedure or stage it? And what do you tell your patients?
I usually tell them it's going to take more than one procedure, and if I'm able to do it in one procedure, everybody's happy. But usually it takes more than one procedure. And the reason being is there's marked incrustation. There may be proximal obstruction with associated infection that requires you to stop and come back another day. But I typically start in a retrograde fashion, and then I reposition them to deal with an antegrade approach to remove the proximal curl and the proximal aspect of the encrusted double J stent.
Okay, and when removing the proximal end of an encrusted stent percutaneously, why do you recommend gaining access from the upper pole?
I think sometimes if you go from the upper pole, the vector force from the upper pole down the UPJ and the proximal ureter is a more direct location. So you could use a rigid scope rather than going from the middle or the lower pole. So typically we place patients in a supine perc where we pull them 30 degrees up. That gives me access from the urethra and then percutaneous into the kidney. However, in this situation, I would do it differently. I would first put them in a formal lithotomy position to optimize exactly to optimize the ability of a retrograde access. Then I would flip the patient truly prone like this with their arms out to the side, so it gives me the ability to do an access wherever I may want to go. Typically the upper pole is easier. The upper pole calyces are medial and lateral in contrast to the lower pole, which are anterior and posterior. So it doesn't matter which calyx you go into, but going into the upper pole, the angle from the upper pole through the infundibulum to the renal pelvis to the proximal ureter is more direct, and you can put rigid scopes in there that increase the efficiency by which to remove the incrustations.
All right, thanks for that very thorough explanation. Now, do you leave a nephrostomy tube in after these procedures?
I think there's no harm in leaving a nephrostomy tube. These procedures typically are long. They potentially could have infectious nidus associated with the stone fragments. And I think leaving a nephrostomy tube overnight eliminates the potential of a bad infectious complication.
Okay, now you mentioned that these procedures can be long. What's the role of your ancillary staff when operating on patients with an encrusted stent?
I think all stone procedures require a team effort. An anesthesiologist that knows what you want to do, nurses and ancillary folks in the operating room that know where all of the equipment is, because nothing is going to be routine here. Do they know where the specialized laser is? Do they know where the flexible scope is? If you're going to use like a flexible LithoView ureteroscope, is it available? Is the monitor available? So having a team, as in all aspects of surgery, specifically with stone surgery, I think is very critical.
Absolutely. Now, what has it been like to participate in the StoneSmart forum? Would you encourage your peers to join the conversation and even share their own case studies?
I think, social media is allowing all of us to be able to discuss things. I could be talking to someone here in India or in China or Indonesia rather than people having to come to San Francisco to see what's happening at our center. And I think participating in the StoneSmart model allows a dialogue for people to understand how I do it in San Francisco, which may be very different for someone doing it in Europe or in Asia.
Absolutely.
Yeah.
I agree. Now, we have some time for audience questions because you did come from San Francisco, right?
Yes, I
so
did.
Who has a question for Dr. Stoller? Go ahead. We'll get the microphone to you.
Stoller, first question is, when do you do, when you're doing a PCNL, when do you do fluoro versus doing ultrasound guidance? And second question is, can you elaborate on the positioning of the patient as well?
Right. So the first question, to repeat it, when do I use fluoroscopy? When do I use ultrasound? I think the ultimate goal for all of us is to reduce the amount of fluoro time you have, period. If you're going to use the fluoroscopy, it should be on-off. It should not have your foot on the pedal all the time. What do you need fluoroscopy for? Any kind of guidance. You want to get the tip of the needle into the calyx and then get a wire through that. Now, if you could do that under visualization of ultrasound, with a 3.5 megahertz transducer, great. And that's what myself and Dr. Chi at UCSF are doing. If there's some difficulty with dysmorphia, the inability to be able to get a probe because of the space between the ribs and the posterior superior iliac spine, then you could sometimes use fluoro. But I think we're moving more and more towards ultrasound rather than fluoroscopy. Either way, there are tools, and the tools are to gain the tip of the needle into the calyx. And by getting that at the tip of the calyx, you decrease the likelihood of bleeding and injury. Your second question is, what is the best way to position? I think if you have a dysmorphic patient and they're all sort of clumped up in a funny contractures, it's difficult to put them in prone position. It's difficult for the anesthesiologist to be able to get an endotracheal tube on some of these folks. So in those situations, if you keep them supine, lift the affected side up about 30 to 40 degrees, and then have access both to the urethra and to the kidney. In that type of position, if you have to go very medial, closer towards the paraspinous muscle, the supine position is not optimal. So if there's some dysmorphia, sometimes you have to be completely prone, and I think you have to individualize for the patient, depending upon where you want to go in terms of access and what their anatomic limitations are, specifically the contractures that they may have.
Thanks for those great questions. Is there anybody else? Oh, yes, please, sir. We'll bring you the microphone.
Can I give you a small case study?
I'd love it.
Okay. I'll take you back to the Stone Age, if you'll excuse the pun.
Yeah.
I'm from Bangladesh. I come from a city, and we don't have the luxury of flexible ureteroscopes or the lasers. Now, this case study is this 70-year-old man who had an open operation. He has ischemic heart disease. He was on clopidogrel, etc., and hypertensive. He had open surgery, pyelolithotomy for staghorn stone. And then he came to see me after about 4 months. This was in May. He came to see me last month. He's got retained stones. He's got a very poor quality DJ stent, which is encrusted. And the first thing we tried to do is, as you said, a retrograde fashion. We did have fluoroscopy. The stent was such poor quality, it just kept stretching like a rubber band, and wouldn't come out. So we tried to do a ureteroscopy, but couldn't advance very far, maybe just above the mid-ureter.
Right.
And he's got a couple of stones there, so, and the system is not dilated.
Okay.
What would you do next?
So to repeat the question, in Bangladesh, an encrusted double J stent was someone with complex medical problems, not unfamiliar to most of us. So again, try in a retrograde fashion, and then you have to stop, and you've got to go percutaneously. Now, you could put an exchange catheter from below to instill a little fluid to maybe get rid of the non-dilated system. But I think ultrasound would be very helpful, or fluoroscopy to gain access to dilate up a tract. If it is infected, I'd put a nephrostomy tube and stop. Bring him back another day. If he's not infected, I would do it just like I would do a percutaneous nephrolithotomy. I would dilate up a tract, 18, 24, 30 French, whichever equipment that you have. And again, the team in the operating room is critical. Be sure what kind of equipment you have. You then go ahead and deal with as many as the stones, and in addition, the encrusted stent, which is part of the stones. You need, in this situation, it's very hard to get a complete staghorn stone free. So in this situation, you may want to do a combined percutaneous ureteroscopic at the same time. So let's say you put them supine, gain the access, you go in there percutaneous, you would have a big tract, you would go retrograde with a flexible scope, and as you're breaking things with a flexible scope into all the different calyces, it's coming out through your nephroscope sheath, and at the same time you could go in percutaneously with your lithotrite with a rigid scope. That's assuming that you have a flexible scope, that's assuming that you've got a laser, and that's assuming you have all this equipment. Now in Bangladesh, you may not have all that equipment, and you have to sort of see what's your best situation. If you could do it at least percutaneously, I think that's going to be the most effective and rapid way to remove the stones and to remove the segment of the encrusted stent that remains in that location. Now the question could be, I can't do percutaneous procedures. I only have the ability to do an open procedure. Maybe in your situation you only can do it open. So you could either do laparoscopic, or you could do it open. You could do a pyelolithotomy like the old-fashioned way that we used to do it, okay? And you could open up the pelvis. One of the tricks that I've used when you do a pyelolithotomy to either remove a stone or an encrusted stent is once that stent's removed and you've done the retrograde fashion as much as you can ahead of time, is you could use irrigation either with like a water pick type situation or just irrigating to get as many of the stones out as you can. If you do it laparoscopically, instead of irrigating with fluid, you don't know where all the fluid's going, you could put CO2 through your scope and you can see it through that way, so you don't have a lot of fluid going into the retroperitoneal or to the peritoneal space. The bottom line is, whether you're in Bangladesh or whether you're in San Francisco, use the technology that's available for you at that time, and be sure that the patient and the family have reasonable expectations of what to have. In your specific situation, you want to ensure that the kidney functions adequate. Maybe in this situation you have a minimally functional kidney, and maybe the most efficient way would be to do a nephrectomy. But those are the situations that you have to weigh with the individual patient and their family. Thank you for the question.
Yeah, thank you very much, sir. Are there any more questions? Oh, we have another one here.
Thanks, Dr. Stoller. That was great. In regards to your informing patients of the likely need for 2 procedures, one retrograde, one antegrade, when you're preparing them, what do you tell them in regards to your expectations for the staging and timing of the second procedure, and what's your preference, and do you think it has, have you seen any differences in outcome when you have the procedures staged at different times?
Yeah. So to repeat the question is, do you try to do all the procedure at once, retrograde and antegrade, or do sometimes you stage it? And I think that's where the clinical judgment comes in. If you feel like there's infection, cloudy urine, evidence of a positive preoperative urine culture, you need to treat them with antibiotics. And if there's any questions, stop. Bring them back another day, okay? And I let them know that even if we do it in 1 or 2 sessions, there is a likelihood that they could get septic. And so it's important to do that. So that's why routinely I will leave a nephrostomy tube, not necessarily a small nephrostomy tube, but just a nephrostomy tube to ensure that we get good drainage. It may not be what the urine culture shows. It may be their endotoxin titer. So there have been lots of stuff in the literature that you may have a negative culture and people become very septic, and that's due to their endotoxins. And presently, we don't have good data to be able to quantitate the endotoxin titer. But that's probably the major factor that will result in them getting septic postoperatively. Irrespective, you don't want to have high pressure irrigation. And the nice thing about using an Amplat sheath versus a metal sheath or an Alkin metal dilator is it reduces the amount of pressure in the renal pelvis during the procedure, and in my mind, that reduces the likelihood of postoperative urosepsis.
Thank you for the question. Are there any more questions? Dr. Stoller, you'll be able to hang out for a little bit, right, and talk to people if they want to talk?
I'm always happy to talk to people.
Okay, well then I guess our time here then is up. Thank you so much for a most interesting discussion and for answering all these great questions. Thanks to all of you for joining us. Now you can view Dr. Stoller's full case and join the online discussion on the StoneSmart forum. Just go to stonesmart.urologytimes.com. And to learn more about Boston Scientific's portfolio of solutions for your most challenging stone cases, go to bostonscientific.com/StoneSmart.